we give people choice. And when they choose well, and we acknowledge that, they see the value for themselves, they see the value for their lives. They feel the connection to the person who's provided this service for them. And in fact, when you ask them what was most healing, they don't say the incentive. Very rarely. They like the incentives, but they say the relationship with the counselor that they had.
Welcome to Dopamine Dialogues, the show where we meet experts working with contingency management, translating the science into what actually succeeds in clinics, communities, and day-to-day operations with patients, clients, and beneficiaries. So whether you're a provider, payer, policymaker, or just CM curious, you're at the right place. I'm your host, Larry Klimchuk. It's with great pleasure that we welcome our guest, Dr. Tom Freese. Tom is currently the director of the UCLA Integrated Substance Abuse Program and adjunct professor at the Department of Psychiatry.
I'm happy to be here. Thank you very much, Larry.
Tom, please tell us a little bit about yourself and how did you become interested in substance use disorder treatment and recovery?
That's a really good question, and it was entirely an accident, if you want to know the truth. I started my career thinking I was going to do clinical services and direct service for my career. It's where my passion was. And I started working with homeless and runaway adolescents on the streets of Hollywood, doing both research and clinical work. And I realized very quickly that while I was not at all interested in substance use and had no training in my PhD program in how to deal with substance use, that if I didn't know something about it, that I was never going to be able to help the young people that I was charged with working with. So over the course of the next few years, I developed a lot of expertise, particularly in the areas of methamphetamine, but really across the board of substance use disorders, and started the substance use treatment program at Children's Hospital Los Angeles in the Division of Adolescent Medicine. So it launched what unexpectedly became a career-long passion for really helping, I think, in some ways, the most needy people to get the help that they need and to be understood that mental health and substance use go so hand in hand that we can't extract them from each other.
Oh, yeah, thank you very much for that. I can see how you would really want to help people there in that homeless and then the children side. And then your last comment as well, Tom, that kind of connection between mental health and substance use disorder. Did you want to expand on that just a tiny bit?
Yeah, the two disorders mimic each other so well that depression may actually have an underlying etiology in substance use, and substance use may mask an underlying depression. And so, unless we really understand both disorders and find strategies for addressing people as whole human beings rather than as parts of themselves, we diminish our ability to truly be helpful. So interventions that take the person and truly help them move in the right direction, either by traditional behavioral treatments, cognitive behavioral therapy, motivational interviewing, those kinds of things that hold people and move them through, but address both disorders, or that don't really directly address them at all, but help them find paths for themselves, like contingency management. If we can just help them begin to make positive changes for themselves, a lot of times they see pathways that heretofore were unavailable to them.
I really like the way you're saying in there, the whole human being
Mm.
treatment. So thank you for pointing that out. Tom, you're leading so much of the work for the California DHCS Recovery Incentive Program, California's contingency management benefit. From what I hear, the California program is the largest CM program. So from your experience, what makes CM successful in scaling and in a real world setting?
Yeah, we have 40 years of research that says that contingency management works. So, in fact, in my opinion, it's really one of the biggest, slowest evidence-based practices to ever be truly moved into real-world clinical settings, because at face value, in the way that people understand it, there's a lot of misconceptions, a lot of misunderstanding, and therefore a lot of pushback against the idea of using incentives to help people change their behavior. I think the core of what makes contingency management work is availability and consistency. We need to make it easy for people to show up in whatever way is required. And we need to make the ability to get incentives so low hanging that they get that success early on. And by giving them that success early on and repeating that across time, we begin to have people help people be able to make choices that different than the ones they made before. So that easy access is critical, but we also have to make sure we're doing contingency management. So we have to follow a protocol that's based on the research evidence and really make sure that what we're doing follows the good behavioral strategies that have been researched so that in the back end we can expect and our clients can expect that they'll get results similar to what we saw in the research.
Yeah, those two key components you just put up there, availability, number one. How do we do that? Because that's not easy, right? You got to get out to the population, or the population's got to get to you. And then the second thing on consistency. So it's one thing to start up a program, but then to have that consistency. Can we expand on that consistency side just a little bit? What are the key things that you focus in on that implementation or fidelity considerations? Is it workflow? Is it staffing? Is it training? Is it QA?
You don't ask easy questions. Um, in truth, it's all of those things. I think we set up a protocol that allows the staff to understand how to make this work in a way that's not intrusive for them in their daily business, but also in a way that works for the clients. So it needs to have some flexibility built in, but it also needs to be consistent in the way that it identifies a behavior that we're going to reward and applies that reward every single time that behavior is seen immediately upon seeing it. And that immediacy effect and that consistency effect is what begins to reshape the way the person experiences the world, particularly in this area of rewards. It helps them see that if I keep moving in this direction, I will keep getting these incentives along the way, which will keep pulling me in that direction. Stimulants are really, really, really reinforcing. And for many people, when they're feeling down, when they're feeling anxious, when they're feeling like the need for some sort of reinforcer, their brain is so hardwired that they don't see options other than stimulants. And if we can provide, evidence shows, if we can provide tiny little rewards and keep those going consistently, even though they don't compete from a dopamine perspective, they don't compete with the power of the stimulants, it happens enough that they begin to see, if I make this choice, I get something good for myself. And if I make this choice, I get what I had before.
Very, very, very well put. And you kind of snuck it in there, but you also had a comment there, but equally important for the staff and the client, right? And so can you share with us just a little bit about your experience in making sure that the staff are trained and they have that fidelity and they have that motivation as well, right? Because this could be a change or a new treatment process for some of the staff. Yeah, what are some of your thoughts on that, Tom?
It's really, in my opinion, an entire paradigm shift. Much of our treatment system has been based on helping people see what they're doing wrong and correcting those behaviors. And urine drug testing we use to catch people being bad, and then we have consequences associated with catching them being bad. And I will tell you, a number of the providers that are involved in the California project, they tell me now on the back end, I didn't think this was going to work at all. I was not sold. I didn't think it was a good idea, but I was willing to give it a try. And what they were concerned about is taking what really was a consequence driven intervention, flipping it on its head, and simply catching people doing something right for themselves and moving them forward with that.
The clinicians were experiencing a behavior change as well.
Exactly that. The clinicians were experiencing a behavior change because it's hard to be positive in the face of someone who's tested positive again and again and again for amphetamines when our goal is to have them not use. But if we can trust the power of the intervention, we can keep supporting them, not have negative consequences for that. We've seen over and over again that people begin to make those changes at very, very high levels. So training is really important. We want to train them how to conduct the intervention, how to test people twice a week, how to deliver the incentives when they're necessary, how to use the tools that we give them in order to be able to deliver those incentives. But we also need to teach them how to respond when someone disagrees with a test, when someone is angry over the fact that they're not getting an incentive on that day, or when they just don't cooperate. How do we deal with them in that way from a clinical perspective that keeps them moving forward and keeps that all positive frame along the way? It takes a lot of training initially, and it takes ongoing support along the way through what we call coaching calls. Where we gather people together and do group learning and group problem solving to help continue to support that ongoing positive intervention.
Fabulous. Yeah, so it's not a one and done. It is, continual progression with them. But I love that you're engaging to make sure that that conditioning, that the training and then the fidelity is there. Tom, you had some great points in there on implementation and fidelity considerations and things like that. People also have, they want to avoid fraud, waste, abuse while preserving that positive participant and clinician experience. Um, do you have any, tips and tricks and things like that for people out there that are considering those areas in a contingency management program?
Absolutely. Those are bad words, fraud, waste, and abuse, and something that, particularly when we're funding it through Medicaid, which gets very close attention in terms of how Medicaid funds are being utilized, and we're giving incentives which have a cash value, it can be very confusing. One of the things that we've done in the California program, and they very wisely did, is they contracted for what we call an incentive manager. And that incentive manager does everything for the clinician in terms of the incentives. The program has been really well developed to make it as simple as possible. So the counselor just logs in, puts in whether it was a positive, negative test or a no-show on that particular day, and the system calculates everything for them. What should the incentive be on that particular day if one is going to be paid? And then they move to another part of the screen, and it allows the client to select the incentive that they want for that particular day and delivers it to them directly by email, by text, or as a printed copy. And in doing that, again, we make that immediacy happen. We give it to them as soon as we see that negative urine drug test, and it takes all the burden out on the part of the clinician. We're helping the state of Montana implement right now. And one of the pieces of feedback that we've gotten with the incentive manager that we're using is that they're so relieved that they don't have to wait in line for gift cards and then manage the accounting associated with those gift cards, but it's all taken for care of for them, which then saves them time, saves them burden, and makes them happy overall in delivering this service. So I think it's really critical that you have some structure in place that is as easy as possible to manage those funds that are associated with incentives to avoid any appearance of impropriety, to make sure that the person gets what they deserve when they've earned it in a timely way.
Yeah, thank you very much. Yeah, but those three kind of components I heard you say is number one, it safeguards the entire process. So that helps with the fidelity of delivery. Number two, for the clinician, it just makes their life easier.
Right.
Clinicians prefer to be spending time with patients, not doing paperwork or filling out gift cards or who knows what other report. And then the last area, the flexibility for the beneficiary, the client, the patient. You know, get it instantly, which is a key component of CM, but then also giving them some choices. And I think you said in your program you got up to 40 different choices. So that's lovely. Thanks for taking the time to talk about that. Tom, I've heard you talk before about just some of the outcomes and the measurements of the California program. For our audience, could you just share some of your favorites?
Providers actually see an intervention that works. Stimulants is really hard to treat, as we said, and most of what we have in terms of behavioral treatment are marginally effective at best. And so we see person after person failing in their treatment that we're, as providers, we're passionately giving them. It is just draining and causes real burnout. But to suddenly see someone make a shift, who one guy said, I've been in treatment for more than 30 years and have never had a negative urine drug test until this program. His urine drug tests were 90% negative throughout the course of his participation in the program. To have a mother say, for the first time in my child's life, I bought their Christmas presents as opposed to stealing them. And she did that through the incentives that she'd earned by staying away from drugs and testing negative for those drugs. Those results on an individual level can't be overplayed. And I could sit here for our entire duration 3 times and tell you nothing but stories like that of people's experiences. But if we look at a whole, Um, the big question was, could we do this in a real world setting with fidelity and make it work? And could we grow that program? We started in April of 2023 with our first member enrolled. And in the last almost exactly 3 years, we've enrolled just over 12,000 people across the state of California in the service. We've trained people in 21 counties and 114 individual locations across the state to do it. And we monitor fidelity on an ongoing basis. And it seems really clear that they're doing it with fidelity to the model. And where drift occurs, we're able to see that and pull them back into fidelity with the model very, very quickly with great willingness on the part of the participants. When we look at the drug testing, finding that if we only look at tests that we conduct, that is, someone comes in, they provide a urine, we conduct that test, we're over 95% of the tests that we conduct are negative for people participating in the program. Now, if we assume the days they don't come in, they're positive, we know that's not 100% true. But if we take the worst case scenario of those no shows, our numbers go down to about 74%. And depending on how we look at it, if people are very actively using at the time that they start, it goes down to just below 50%. But even with those numbers, those are tremendously higher than what we see in any other stimulant use treatment program. One of the questions was, okay, we get people to come and we get people to sign up for the program. Will they stay in the program? And an early look at that, because we're in process right now. So an early look at retention data shows that we get about two-thirds of the people past the most active phase of the program, which is the initial 12 weeks. So two-thirds of people stay in, coming in twice a week for testing, and are still there at the end of their 12th week. About half of those drop off once the incentive lowers along the way. And so we get half of that two-thirds or one-third of the population all the way to 24 weeks. But two-thirds staying in treatment for at least 12 weeks, again, much higher than we see in other stimulant treatment. And about 20% stay in for about a month, and somewhere in the neighborhood of 10%, we don't really engage at that particular time. We get it. It's a hard disease. It takes people time sometimes. And for all of those people, if they continue to meet criteria, they can re-enroll. And so they can try again if it's worked for them and they have a continuing need for treatment, or if it didn't work for them and they want to try again, that option is available to them.
Nice numbers. I mean, the first thing that you were talking about there um, was it is maybe a misconception that contingency management can't scale, and you've just disproved that with those numbers. That's for sure.
It's really fun for me to watch people's faces when we talk about how many people we've enrolled, because we're surprised by it. Our initial goal was across the almost 4.5 years of the program that we would enroll 10,000 people. And we're approaching our fourth year now and have beaten that goal by a considerable margin. So by the end of this funding period, we'll definitely have far surpassed that goal.
Are there any other misconceptions about CM that are still out there? I mean, after 40 years, you'd kind of hope that they'd be gone.
I think there are a number of misconceptions that people have about contingency management. First of all, a lot of people think that if you just use incentives in any way that you're doing contingency management. And it's really not the case exactly that, a bowl of candy on your desk that everyone gets access to, or a pizza party every once in a while for a program that's doing really well. Those are really great and fantastic uses of incentives, but they're not designed to create behavior change in the way that contingency management is. It's also not paying people not to use. Again, the other big misconception. Are we using incentives? We absolutely are. But they earn those incentives by demonstrating a contingent behavior. If I show this behavior, I will get an incentive. And what we're actually doing from a neurochemical perspective is we're rewiring the brain's reward system a bit, that dopamine system, and allowing something else to charge that system so that, as I said before, people can make that choice of this reward versus this reward, as opposed to being driven compulsively toward the thing that's taking them down. And so by impacting that reward system in that way, we really are reshaping how they function in the world.
Tom, tell us a little bit about, all your experience, all these big projects, everything else. Where is contingency management headed next? Or, what's the future look like to you?
Well, that's a really good question. I think that finding ways of both funding and scaling contingency management still has a lot of work to do. California is funding their program through what they call an 1115 waiver with Medicaid. Medicaid, we call it Medi-Cal. Medicaid allows for pilot projects to spend those dollars in a different way to demonstrate that if we do it this way instead of the traditional way, we'll get a bigger bang for our buck, as it were. And so the California project wrote their 1115 waiver, they wrote in contingency management, and the Center for Medicaid and Medicare Services accepted that, and that's how we're funding the program. So it is a billable Medicaid service. There's a few other states around the country that are doing similar kinds of interventions. Montana, Washington are both either on the verge of implementing or have implemented, and there are other states that are in that process. It can't be the only way, though, because not everyone has Medicaid. And so SAMHSA has loosened up some of their regulations to allow for more reasonable incentive amounts through the state opioid response and tribal opioid response grants, which opens up funding opportunities as well. And there are a number of programs that are starting looking at opioid settlement funds as a way of launching pilot programs of various sizes to demonstrate its efficacy. But if we don't find a way to work this into our normal healthcare system and to make it available as more routine practice, again, with appropriate training, with appropriate monitoring, with all of those things, it's hard for me to see how it becomes sustainable at the breadth that it needs to in order to meet the massive methamphetamine problem that we have in this country. And so we have a treatment that works. We need to make it available to people. That's where we started this conversation. And part of that means fixing those funding issues and those misconceptions so that we can make the service available. I think we'll get there. I think we're moving there. We see more and more pilots happening all the time, but I can't wait until those pilots all come together and have a body of evidence that makes it irrefutable that insurers of all sorts and other kinds of payers must provide this service.
So you see the future where contingency management will be across a much broader area of total healthcare.
Yeah. I think it also gives us an opportunity to look at other focused behaviors other than stimulant use. We started with stimulant use because, one, people were dying at increasing rates from stimulant overdoses, both alone and in combination with fentanyl. And so it was addressing, in part, that overdose crisis. But we also have the largest body of research in those 40 years around stimulant use disorder. But there's significant research with other focused behaviors, alcohol, medication compliance, attendance in treatment, et cetera. And there's a pretty good significant body of international research and research with other cultures within our own communities that demonstrate that it works with a variety of different populations as well. So we need to look at how to make it available to those populations who need it for those conditions that it would be appropriate for.
You just mentioned international, Tom. Your experience outside of the US, do you see contingency management varying dramatically, or is it subtle to the individual culture, or is it exactly the same?
I think that there are some core fundamentals that are essential to contingency management. We have to have a single target behavior. We have to measure it in a way that's objective, not subjective. We have to deliver incentives consistently every time we see that behavior. And we have to make sure we're not delivering incentives if that behavior is not seen. Those are core. It doesn't matter where you're doing it. It doesn't matter who you're doing it with. What is really critical, however, is what are we offering as incentives? It needs to be desirable and valuable to the individual who's receiving it in order to make it have the weight to counterbalance and impact that reward cycle that we talked about earlier. So in the California project, I think we currently have something like 40 different gift cards that people can choose from that so that they can choose something that's valuable for them. There was a study that was done with tribal communities out of Washington State University, and they had to work with the local communities to find incentives that were meaningful not only to the individual, but that could contribute to the community because that community contribution was seen as important, or in many cases more important for the individual than any kind of individual reinforcer along the way. So it's finding that right incentive for that community where we need to do significant community involvement and adaptation in order to make it work.
That's very insightful. I mean, obviously, that first choice of what's the behavior, but then also what's the incentive that's going to make the difference. Combining that then with the right training, so you've got consistency and fidelity. So these are all key components that need to happen, and that's what it's all about. Is we're actually trying to improve the quality of everybody's life. So, Tom, I've only got one last question for you. And that's what else would you like to tell me? I've heard a few of your stories in the past, but then again, maybe you want me to ask you a direct question.
Yeah, thanks. I can't think of a question. What I can think of is, and what again lights up my face is the experience of people who participate in the program. At the end of their 24 weeks, those who are still active, they get a certificate at the end. It's a piece of paper that gets printed off of a printer. Some people make it more special by putting it in a frame, other people hand them the piece of paper. The feedback we get on those certificates is so amazing and powerful. People will say, I've never finished anything in my life before. So to have something recognized in this way is so meaningful. Or I've never graduated from high school or even from elementary school. And so I've never gotten any kind of certificate in my life. And so I got this because I did something good for myself. Those stories are so powerful. And what we do with contingency management, as we've talked about throughout this whole interview, is we give people choice. And when they choose well, and we acknowledge that, they see the value for themselves, they see the value for their lives. They feel the connection to the person who's provided this service for them. And in fact, when you ask them what was most healing, they don't say the incentive. Very rarely. They like the incentives, but they say the relationship with the counselor that they had. And by that, they mean the person delivering the contingency management. So through those relationships and through those ability to make different choices, lives are changing. We need to get together and do this for real on a large scale.
What I just heard from you there was, yeah, people do make choices, but, CM and that interaction with their counselor is helping them make the right choice or choose well, I think is the actual words that you
Yeah,
said. And finally, yeah, the incentive is nice, but the most powerful thing is the human connection. And that's why this is called a treatment, right? This isn't a payment. This is contingency management treatment, and you placed it extremely well there. So thank you very much for that as a wrap up. Tom, I've learned a lot in this short conversation. So thank you very much. As always, I can see the passion in your eyes and your smile that this is, what you love to do. You love changing the world
thank
and everything from starting off what you were saying, working with homeless and people with substance use disorder to what you're doing now at a very wide scale. And I think you've also got a vision on how big this can actually be. So, on behalf of all of our listeners, I'd like to say thank you very much for your time.
thank you, Larry. I've enjoyed our conversation.